We often just assume, don't we, that AI in medicine, like, say, radiology, works best when humans and AI collaborate really closely, side by side, a team. But what if that whole idea, that prevailing view, is actually, well, wrong? Okay, let's try and unpack this. Today's deep dive really challenges that assumption. We're looking at a source called Beyond Assistance, the case for role separation in AI-human radiology workflows. It suggests something pretty different. So what's our goal here? What are we trying to figure out?
Well, our mission really is to understand why a clear division of labor where the AI and the radiologists have separate jobs might actually give us more reliable results, better diagnoses. It's about using their unique strength, without forcing this kind of awkward blended process that often causes problems.
Right. So let's talk about that traditional model first, the assistive AI. That's mostly what we've seen, isn't it? The AI takes a first pass, maybe flags things, and then the human radiologist reviews it all, makes the final call. The assumption being, obviously, that the AI helps catch things, improves decisions. Seems logical.
It does sound logical. But what's fascinating, truly, is that this model, which seems so ideal on paper, has run into some pretty big real-world hurdles. It often triggers these very human cognitive biases, like automation neglect. There was research, for instance, on chest x-rays, finding that radiologists sometimes actually discount correct AI suggestions. They ignore them.
Ignore them, even when the AI is right. Why?
Yeah, often it's because they've seen the AI make mistakes before, so trust erodes. They end up dismissing good info along with the bad. And then there's the flip side, automation bias. This is where radiologists rely too much on the AI, even when it's wrong. There was a study on mammography interpretation. It showed experienced radiologists' accuracy just plummeted.
Plummeted? How bad?
We're talking from like 82.3% down to 45.5% when they were given flawed AI advice. It's a massive drop.
Wow. Okay, that really forces you to reconsider the whole AI assistant idea. These biases are serious practical challenges.
Exactly. It shows how tricky it is just to blend human judgment and AI output seamlessly.
So if that standard approach has these, well, hidden dangers, what's the alternative? This is where it gets really interesting. The paper proposes this different approach, the role separation framework. It's not about merging tasks. It's about strategically giving separate jobs to the human and the AI, letting each do what they do best without getting in each other's way.
Precisely. And the framework lays out three main models. First, there's the AI-first sequential model. Here, the AI does a specific job up front, then the radiologist takes over for the interpretation part, like AI preparing the ground.
Okay, give us an example.
Sure. AI could pull together relevant clinical histories from electronic health records before the radiologist even looks at the image. One study found GPT-4 did this so well that 89% of radiologists preferred its summaries. It uses AI's speed with data so the radiologist can focus immediately on the complex thinking, the diagnosis.
Makes sense. What's the next model?
That's the doctor-first sequential model. Here, the radiologist starts the process, makes their findings, and then the AI performs a separate complementary task.
So the human leads.
Exactly. For instance, the AI could take the radiologist's free text notes and turn them into a structured report, something achieved with, I think, about 84% precision in one study. Or another example, AI could translate the technical interpretation into a patient-friendly video report. There's a system called Rexplain that does this, really helping patients understand their results.
Interesting. Okay, and the third one?
The third is the case allocation model. And if we look at the bigger picture here, this model uses AI to sort or triage cases based on their characteristics. So AI could be used to reliably screen out the definitely normal cases. Think about chest x-ray systems like Oxford's ChestLink aim to do this, freeing up radiologists significantly.
Right, filtering out the straightforward stuff.
Exactly. Or in dermatology, a system called DERM achieved nearly 100% accuracy, 99.8% negative predictive value for ruling out melanoma in benign skin lesions, safely keeping them away from specialists. AI can also triage based on risk. The Anti-Eye trial, for example, used AI for risk assessment in breast screening. It led to finding 29% more cancers while reducing radiologist workload by 44%.
Okay, so when you put all this evidence together, what does it really tell us about the best path forward for AI in medicine? It seems like neither just sticking AI alongside humans nor full automation is the answer.
That's the key takeaway, I think. The most pragmatic approach seems to be this careful, measured role separation. But, and this is crucial, it has to be guided by really rigorous testing and validation. We also need to stay flexible. We're seeing these powerful generalist medical AIs starting to emerge, things like Medversa that can handle different types of scans, draft reports. That means we absolutely need clear clinical certification pathways for these AI systems, much like the training and certification doctors go through.
So the future isn't just AI helping humans in fields like radiology. It's more about smart, strategic separation of duties, playing to strengths. It really does make you think differently about what collaboration means in this context. What stands out to you listening to this? How might this idea of structured role separate and apply in other areas where human expertise and AI capabilities are starting to meet? Something to think about. Thanks for diving deep with us today.